para que todo se siente muy cómodo, voy a decirle una historia. Y como todas las historias, se empieza con la frase, había una vez. Es la historia de la cirugía mitral. En 1900, en London, esta época, la cirugía es como eso, con caballos, sin automóviles, todo, sin antibióticos, sin la cirugía de tórax. Y fíjate muy bien que esta es una revista más conocida del mundo, The Lancet. Un cirujano se llama Dr. Brunton. Dr. Brunton wrote a small article in The Lancet talking about the possibility of operating on mitral valve disease. You must remember in 1902 to have a diagnosis of mitral disease, either mitral stenosis or mitral regurgitation, was a death sentence. There was no treatment at all. So he entertained the idea in 1902 that perhaps it was possible to operate on the valve to fix it. So he wrote this little article. He was at St. Bartholomew's Hospital in 1902, and his patients, he operated on los gatos, pero los gatos muertos. So, ningún de pacientes ha sobrevivido a la operación. But he proposed the idea that the mitral valve could be manipulated. So after his thought, it went 20 years without anything happening until this gentleman and his friend, Elliot Cutler and Claude Beck, approached the mitral valve through a left thoracotomy and put their finger into the left atrium through the left atrial appendage and tried to force the valve open. They did it for, let's see, they started in 23 and 29. They reported in 1929, they had operated on not even a dozen patients. 90% of the patients died, and they gave up the procedure. In 1925, Henry Sutar also tried the procedure in 25. He published a paper on it, and this gives you some idea of what they would do. They'd put a purse string on the left atrium, stick their finger in, sometimes with a little knife that curved along the curve of their finger, and they'd try to split the valve open. Again, the results were terrible. Most of the patients died. So there was a long hiatus where nothing happened. So for almost 20 years, nothing happened until these two surgeons came about, Dr. Bailey at the Hahnemann Hospital in Philadelphia and Dr. Harkin at the Peter Bent Brigham. So I'll tell you a small story about Dr. Bailey and his attempts at breaking open mitral stenosis. Again, they used a thoracotomy. Again, he used a knife. He did it at Hahnemann Hospital. He operated on 5 patients. They all died on the table. He scheduled a 6th patient for surgery, and his chief of surgery came to him and told him, if this patient dies, 1, you'll never do this operation again, and 2, you're fired. Bailey took the 6th patient into the operating room, did the thoracotomy, split the valve. The patient died immediately on the table. He ran out of the operating room, grabbed a taxi cab, went over to Jefferson Hospital on the other side of town, where he had another patient waiting on the table. He did the same operation, put his finger into the heart, pulled it out. The patient lived and actually survived another 20 years. At the same time, Harkin in Boston was working on the same procedure. So for the next 5 years, if you went to any thoracic surgery meeting, these two surgeons would argue. They'd say what the other guy did wrong and what they were doing right. And it was a show for 5 years. All you heard was Harkin and Bailey, Bailey and Harkin. And they made some progress. More patients survived than not. It was still a desperate operation, but there were other things happening outside the limelight, which changed the face of heart surgery. Am I stuck? Here we go. So one was a gentleman down at Temple University, John Gibbon, who from the 1930s, he and his wife, Mary Gibbon, were both researchers, were attempting to develop a heart-lung machine. In 1935, they had their first success where they had a cat, another un gato vivante, and they had the cat live after having been on a heart-lung machine for 26 minutes. He was made of a point of, he was a big joke in the Department of Research. People would go by and they'd see John and Mary working in the department, working on a heart-lung machine, and they'd go, look at him. Okay, payaso. He's trying to make a heart-lung machine. It's imposible. Un verdadero payaso. It's imposible. But in 1953, he perfected his first machine. And the first successful operation was done on heart-lung bypass, which was the closure of an ASD. That changed heart surgery. All of a sudden, you could open the heart and the patient would survive. The next thing that happened was a Canadian gentleman, Bill Bigelow, who was raised out in Saskatchewan. And he was a farm boy. And the reason they're the little animals on the right was every once in a while, these prairie dogs would get caught out in the open in the winter and they'd freeze and they'd find the animals rolled up in a ball. And Bill learned, it was the farm boys did this as a joke. They'd take the frozen dead animals and they'd warm them up and the animals would come back to life. And so they realized that hypothermia was probably important in preserving tissue. He also learned that you could shock a heart that had stopped because of cold and it would start again. So with these two developments, a heart-lung machine and the use of cold and the use of a pacemaker, heart surgeries took off. Now, since there were other indications for surgery besides just doing a commissurotomy and opening the mitral valve, they developed heart valves. And these are some of the initial valves that they had. Some were pretty primitive, but they were a start. And they'd sew those in, they'd take out the valve and sew in the new valve. And so from 1953 to the 1970s, mitral valve surgery got better. But it was all valve replacement. And the only repair that they could do was to cut the valve, trying to open it up. So by the 1970s, things had started to improve. And then from probably 1975 on, there was another revolution building in Paris, where Alain Carpentier published finally the result of about 8 years of work called the French correction. in which he established the principles of how to repair a leaky mitral valve, so mitral regurgitation. And this what he called the French correction. And this was a true revolution again in heart surgery for the mitral valve. First of all, he understood the anatomy better than even Da Vinci did in his drawings. He, with the usual rational mind of the French, he analyzed how a mitral valve works, came up with a very simple system for describing what could go wrong with the valve, and then gave us ideas on how to fix it. And these are just the technical things that you can do to a valve to fix a mitral valve. But he rationalized the system, showed people how to do it, and published the fact that mitral repair was superior to replacing it, especially with these prostheses, which required anticoagulation, and the repair did not. So the advantages, it had a lower mortality. There wasn't the problem with emboli. They lived longer. They had much better ventricular function, and they didn't need anticoagulation. So then the topic in surgery, once he published his results, was, do you replace the valve or can you repair the valve? And so we came up with, in replacing the valve, we had two basic options. We had a bioprosthesis or we had a mechanical valve. The bioprosthesis had the drawback, it didn't last forever, but the anticoagulation was not as intense. The metallic valve was very durable, but required intense anticoagulation forever. And in the repairs, we knew that they didn't need to be anticoagulated, and the anticoagulation was just short term. So that was pretty much up until the early aughts in 2000, what we did. Everything was approached through a sternotomy. It was repair or replace. We had the heart-lung machine. We had hypothermia, good myocardial protection, and that was pretty much what we had to deal with. Then the next step becomes the minimal invasion, is how can you do the operation with less trauma? So we had the full sternotomy. Then we had robotic or portal systems for thoracotomy, and certainly then catheter-based procedures began to become a possibility. There we go. So first of all, I'd like Arne to step up for a second, because this is Arne Geersen, who's the chief of cardiac surgery at Yale, and he's also our leading innovator for the robotic mitral valve repair program. So Arne, I had him stand up. This is sort of balking. There we go. Now, I had Arne stand up so that you wouldn't think the robot looks like that. The guy who runs the robot looks like that, not like that. So this is what it actually looks like in the operating room. It's very impressive. Arne says we get better visualization than we get from a sternotomy. And I'd have to agree with him, having watched him do these. It takes him a little bit longer to do it than, say, it takes me through a sternotomy, but his patients don't stay in the ICU as long. They don't stay in the hospital as long. They don't get transfused as much, and they have less atrial fibrillation. In terms of the long-term results, it's about the same. But this gives you some idea of how well he sees things. Those are his robotic arms. So you see, he runs the robot. He doesn't have robotic arms. He has normal arms if you look over there. This is what the scar looks like at the end. They go back to work earlier. However, there are some people who you can't do that to. People who have a lot of aortic insufficiency, who have severe pectus excavatum, can't have this, who have really bad LV function or significant mitral annular calcification. That's sort of a contraindication to any mitral valve repair. A lot of mitral annular calcification sort of makes it really difficult to repair a valve. Prior right lung surgery makes it hard, and multiple coronary artery blockages also make it difficult to do. But his results for 200 robotic mitral valves, you can see here, and the results are really quite outstanding. So it's definitely an established technique in the right hands. That's mitral valve repair with a robot. Now we come to the next step in progress, which is a catheter-based mitral valve repair. So no incisions at all. And this is by and large the mitral clip. I'm going to have to start saying next. So this is the principle of the mitral clip. It's done with a catheter introduced transatrially, and basically the two edges of a floppy mitral valve are positioned together with a clip, which reduces the mitral regurgitation significantly. And it's done all without any incision at all. Relatively effective. That's what it looks like when they're done. And primary effectiveness is it does work. It does work. We can't deny that, but not all mitral anatomy is good for a mitral clip. Am I pointing in the right direction? There we go. So now we've done two ways to do the mitral valve repair. Now the question is, can we do a transcatheter mitral valve replacement? This is still a work in progress. This is from 2021, the last current evidence, and it's uncertain. There have only been about 300 done. It's uncertain whether or not this is going to be better than a regular orthodox replacement. It's being worked on. There's several different models. The catheters are new. The approach is uncertain. Some are going transatrially, some are going transventricular. And there's several anatomic problems with doing this. One is impingement on the left ventricular outflow tract. And then the other one is getting something in the mitral valve to anchor to. So this is akin to the TAVR, but the TAVR works really well when the valve is calcified because there's something to hang the valve on. The mitral doesn't have that, which makes it more difficult to do. These are some examples of the kinds of valves they're using for the transcatheter valve replacement. So as I said, the challenges are impingement on the left ventricular outflow tract. The mitral valve anatomy is more variable than the aortic valve, and some of the valves just aren't going to fit the annulus. So right now, the indications are for non-surgical candidates, people who have a previous mitral prosthesis, because that's a valve in valve, and that gives you something you can anchor the new transcatheter valve on. And when they have severe mitral calcification, you can try it because, again, that gives you something to anchor the catheter valve on. Preliminary results are not bad. In 350 patients worldwide, 92% technical success, 4% conversion to sternotomy, 4% obstruction of the LVOT, operative mortality 2%, 30-day mortality 13%, which is rather high, 1-year mortality at 23%. Durability, unknown. So in addition now to replacing the valve, repairing the valve non-invasively, replacing the valve non-invasively, there's all sorts of other things we do which are sort of value-added procedures. We burn the left atrium, we stuff the left atrial appendage, or we strangle the left atrial appendage. So we do the Mays procedure. concurrent with with an open mitral, which eliminates AFib, or at least cuts down the incidence of atrial fibrillation. We can exclude the atrial appendage, either with a catheter, which is on the left, which is the Watchman device, which stuffs the left atrial appendage and then it seals off. Or a lot of times in the operating room, we put a clip at the base of the left atrial appendage from the outside. So that excludes the atrium. So ablations, occlusions, isolators, the whole idea in this part, in addition to fixing the valve, is to reestablish rhythm, exclude thrombus. So in conclusion, mitral valve surgery, we started with the closed mitral commissurotomy. Then cardiopulmonary bypass hypothermia were discovered. Mitral replacement became routine. Mitral repair was declared and perfected. Then minimally invasive approaches to the mitral repair and replacement, transcatheter mitral repair, transcatheter mitral replacement, open and closed ablation for atrial fibrillation, and exclusion of clot formation in atrial appendage. So final thoughts about mitral valve surgery from 1902 to 2022 is we've started an era in which we can treat diseases effectively with a degree of safety in gravely ill and elderly patients that early surgeons couldn't even dream of. However, we're far from perfection. Complications and death still haunt our clinical lives and our patients' lives. And we shouldn't be seduced by the power of our technology into believing that we can cure everyone and that we have no limits. The application of our techniques will always require wisdom and judgment and humility. We need to know what our patients really want and what they can really expect. And to close, I thought I would quote my mentor from McGill about surgery in general and the practice of medicine in general, is that surgery is not primarily a business or a technology, nor is it a pure science or a pure art. It's basically the care of one human being by another, a relationship involving, to some extent, technology, science, art, and business. It's a relationship involving invasion and manipulation of one individual body by another. And it's a relationship requiring the human touch, el toque humano. And I think we should never forget that while we practice, that that's really what we're doing, because it's kind of magic. And it's important to understand that kind of relationship between us and our patients. So I thank you all for your attention.